Hey everybody, my name is Liz. I'm one of the staff members here at CDH and TGH, and I'd like to welcome you to Tales from the Trenches. This is our first webinar in quite some time. I think over a year or so, something like that. Anyhow, pardon me. As you may be aware, staff has been very busy working hard to refresh the content, the video content of our sites. And we've gotten a lot of great suggestions from our members, and I'd like to just thank you. This has all been because of our members that we've taken this time to rejuvenate the video section of the site. And so thank you so much to everyone. Now, if you just bear with me for a moment, I'd like to give a shout out to a few of our staff members who have really made this possible. Kimberly and Jasmine, they have been instrumental in producing content for the webinar series and for just handling all the production elements and everything. And I appreciate the efforts that both of them have made to get this all running. And I'd also like to give a shout out to our founder, Vanessa Wall, who handled a lot of the technical stuff on the back end and really helped drive this along. And so just want to say a few more things about this initiative. It hasn't been easy. There's been a lot of technical and logistical challenges that we've had that we've overcome. And it took several months to make all this happen. We basically had to start from scratch on this. So anyway, here we are. And before I get into introducing Dr. Dee Haggerty, I just want to do a couple of housekeeping items here. First of all, if you have any questions, feel free to post them now in the chat window. You don't need to wait. We're going to be handling questions and answers at the end of Dr. Dee's presentation. So, but if you have a question that you want to see asked, then go ahead and put it up in the chat window and we'll get to it. We'll answer as many of the questions as we possibly can. And the other note that I'd just like to make is that if you're watching on a mobile device, a cell phone or a tablet, you're going to get a much better experience if you watch directly on the YouTube channel. If you are watching on TGH or CDH on your mobile device, you'll notice that you have to go back and forth between chat and the video, and it's really not the best experience. So just move over to YouTube, and I think you'll be a lot happier with that. Pardon me. And so without further ado, I'd like to introduce Dr. Diane Haggerty. Many of you know her as Dr. Dee. Dr. Dee practices medicine in rural Alabama at the moment. Before she set her sights on family medicine in Alabama, she taught and practiced medicine in several large cities around the U.S. And she's been treating trans patients for over 38 years. And for the last 3.5 years, Dr. Dee has been a patient herself. Dr. Dee is trans. And so, Dee, I'm gonna let you take it from here.
All right, Liz, thank you so much. And thank all of you for being here with us and taking time out of your busy Saturday. It's a pleasure and a privilege to be here with you. And I'm going to go back and echo just a few comments that Liz made. Liz, Kimberly, Jazz, they're really the ones that sweat bullets and pushed boulders uphill with their noses to make this happen. And I can tell you, they're wonderful people to work with. They have really made my life a lot of fun for the past several months. All right, so we're rejuvenating the video section for you, our listeners. Lots of great suggestions. There's some things that kind of come up on a regular basis on the sites, and we figured that would be a great place to start. So everybody asks about gender-affirming hormone therapy. Well, I'm going to give 2 sessions on exactly that topic. But today's particular issue is really trying to get you to think in a broader term for your gender therapy, in that there's a lot more that goes into you than just pills, patches, and shots. So today, our business at hand is going to be talking about systems of care. And it doesn't make any difference what continent you're on, what ocean you are across, or what healthcare system you're involved in. Most of what I'm going to say today is applicable to all of us. Liz is really an insightful person, and some of our conversations, she's brought up really a fundamental point, and that is most of us, as we're going through our gender care, just are not very good advocates for our own care, and we just kind of bob around in the system. So with this episode, I said we're going to talk about the systems of care, but also the general categories of care content. Our next week's episode, we'll take a deep dive into the specifics of hormone therapy. We are anticipating that y'all are going to have a lot of questions. We're here to answer those, and we're going to collect those that we can't get to today. We are going to have a third episode simply to address your questions. All right, so let's then move along into our first section that's going to be systems of care. All right, so what am I going to do for you today? You're spending your time, and we're going to try to entertain you. Hopefully, I'll leave a smile on your face when you leave here. And in the process of entertaining you, I'm going to try to educate all of us about those systems of care and the content. And then hopefully along the way, we'll eradicate a couple of false notions that some folks do have. Now, let me take a moment to kind of explain who I am. Unfortunately, the very first thing is, I really am a dinosaur. If we have a little bit of time at the very end, if somebody will ask, I'll tell you my story that helped me to cement in my brain that I truly am a dinosaur. All right, so let me tell you a little bit about the professional me. You saw all those letters after my name. I've been somewhat of a professional student, kind of a pocket protector, slight carrying kind of a geek, but I've kind of reformed myself. But anyway, I did a bachelor's degree in chemistry. I then did a master's degree in physical chemistry. Both of those were at the University of Missouri. From there, I went to Case Western Reserve in Cleveland, Ohio, did my PhD in physical biochemistry, went to the NIH and did a postdoctoral fellowship in biochemistry. And then a really smart person convinced me that I needed to go to medical school. So then I went to medical school at Emory University in Atlanta, Georgia. And during my first year of medical school, I did my Master of Public Health in Chronic Disease Epidemiology. And I really did do that while I was a first-year medical student. When I left my training days, I was my first 20 years was in academic medicine. My gig was to start family practice training programs for physicians who are going to go into rural practice. But as I was introduced, I am trans. I've known about that since I was 6 years old. So I've been working my whole life to bring education about the care of trans individuals to the physicians in training who would then, be the ones who would populate our country caring for us. My background, and I'm usually pretty good at telling a story and stringing sentences together in understandable bits. So I got to be a TV doctor in the early days of being physicians being on TV. And with that, I had my own shows, all things in the political world. I was chosen to give a speech for the American Academy of Family Physicians during the Clinton White House days when they were first working on healthcare reform. Now, I'm going to give you a little bit of a trigger warning. This next couple of photos might get some hairs up. But some of you might think that these are a couple of pretty handsome fellows. One of them happens to be me, and you can probably guess which one that is. So here I am in the Oval Room of the White House. And you can see Hillary in the background, and you can see Tipper Gore back there. This was our meet and greet before going out to give a speech on the South Lawn of the White House. I was the physician who was asked to talk about what it meant to the healthcare providers that there really should be reform in our system. So we left the Oval Room, went out here to give a speech. Now, before we got there, you'll see a fellow on the walkway back there. He's coming out of the exit from the Oval Office. The way we were lined up, the president and Hillary were in front. I was immediately behind the president. And as we were lining up, a really big, really scary Secret Service agent put their arm around me and took me aside and gave me my instructions. Because everything, of course, is scripted when it comes to politics and the television and the president. I said, Dr. Haggerty, you can walk no closer than arm's length behind the president. Whatever happens, if the president stumbles or trips, you must overcome the urge to try to help them. You cannot touch the president of the United States, even if he falls to the ground. And let me tell you just how important that is. Look across the street. On the top of that building are several snipers. There's one of them that has one job, and that's you. If you move any closer than arm's length of the president, that sniper has one job. Now, that was all he said. And then we all walked out. And of course, I was the person that was supposed to give the first speech. And that was kind of difficult getting things started. But all went well. Obviously, I'm still here, so the sniper didn't have to do their job. This was kind of a watershed moment for me. I was on TV, CNN, I had my 15 minutes of fame, but I realized this was something I was doing more for me than I was for my community. This was the day that really started a transition in my mind that maybe I should be doing something a little bit different. So my next move after I left academia was to move here to little rural South Alabama to practice medicine. And for the past 24 years here, I have enjoyed treating transgender patients. But it's my treatment here is really that eyeball to eyeball, one person at a time. And I am a true old-timey family physician. I treat people cradle to grave. I've delivered over 1,500 babies. So that is my life here. I see transgender patients on a regular basis. Typically, I have about 10 to 12, 13 office visits a week with transgender patients. So they really are an important and very fulfilling part of my medical practice. Okay. Now, who am I personally? Well, I'm staring towards my 70th birthday. I've been married for 37 years. I have 2 children. I really enjoy living here. South Alabama has been wonderful for me, and I've not had any issues being a trans person out and about. I'm not socially transitioned here in town. That's coming very soon, and the sooner the better as far as I'm concerned. But I really enjoy living here and working with my trans patients. But being a trans and walking this journey with you, I'm like many of us. I'm that ugly duckling gazing into the mirror and gazing into the pond, hoping that that beautiful swan one day is going to be me. Uh, like I said, I'm staring at my 70th birthday. So most of you are going to think that I'm a late bloomer, and I kind of am, but I'm really working to make my life successful as a trans individual. And helping trans patients has helped me to understand a little bit about life. We have to really work and plan how we're going to get through this. And if we do, things are going to be great. Unfortunately, if we don't plan our care very well, it's just not going to turn out quite so well. Okay, let's do a little bit of housekeeping. The things that I'm going to be talking about are medical standards of care and best medical practices. Now, nothing that I'm going to say here is the only way to do things, because we all know there's more than one right way to do things. A bunch of really smart people got together called the WPATH. You've heard of them before, the World Professional Association for Transgender Health. And they've reviewed the medical literature. They sit around and they really chew on these things, and they've come up with standards of care. And again, it doesn't make any difference where you are on planet Earth. It really serves as a roadmap or a script for the kinds of care that we are supposed to receive as transgendered individuals. There are 18 chapters to the standards of care in the version 8. They've matured a lot over the years. One of the terms that you'll see throughout those standards of care is the TGD, which stands for transgender and gender diverse individuals. As I said, a bunch of really smart people got together and they looked through all the medical literature. They thought about what are the things that we really need to do for transgendered individuals, both transmasculine and transfeminine. The very first standards of care were published all the way back in 1979. Now, back in 79, think about that, 46 years ago. We really didn't know a whole lot. So some of that really did seem like amazing things to us in the medical community when they brought these standards forward. I'm going to try to refrain from giving you too many opinions, but if I do, I'll tell you which of those are based on fact, which of those are based on experience of years. I will really try to refrain from offering value statements. However, almost everybody will understand where I stand on certain issues. And sometimes I'm just plain old going to get it wrong. I do fail. And I hope that over here in the comment windows, y'all will put those up there and keep me on the straight and narrow. As you have probably already guessed, I'm a real Gary Larson fan, almost fanatical, and you'll see a lot of his cartoons scattered throughout our talk today. All right, so now let's talk about you, the patient. What kind of person are you? Well, when you walk into my door, I want to meet and treat all of you from the top of your head to the bottom of your toes and everything in between. Now, everybody who has ever come into my office is a whole person, and I have never met this particular patient. Well, actually, I have. I know this young lady very well and have seen her on her journey. But she really gave a great description of some of the turmoil in her life and feeling like this thing wasn't connected to all of this thing. And that really brings home a point that none of us should leave this discussion today without really understanding. What kind of a patient are you? There is a critical importance of your mental health provider. They're so critical that we, as physicians and surgeons, we just can't do our job without them. So much so that most of us on the medical treatment side or the surgical treatment side just won't commit or get involved with you as a patient unless you really have a very active relationship with your mental health provider. All right. Now, let's talk about just some of the basics of how we're going to meet your needs as a patient. Now, many of you have heard the first one, primum non nocere. It's that philosophical orientation that of all things, it is most important to do no harm. Now, almost juxtaposed to that, but at least on a nearly equal footing, is the patientis venti primum, which stands for the patient comes first. We've also heard it said a different way, the customer is always right. Well, put those side by side. How do we as healthcare providers deliver care to you to try to make those two things work out optimally? Now, let me give you an example of how sometimes they don't work together. I have plenty of patients who come to me in their 60s and 70s who are going to begin their medical transition and they want to start on hormone therapy. I say, well, doc, I've been waiting a long time and I may not have a lot of years on this planet. Let's kind of double the dose of my hormones and let me get there faster. Or maybe if I do more estrogen, my breast will grow faster and better. Well, that's the venti primo. The patient wants this, and you come first, and we're trying to meet your needs. But as a healthcare provider, I may not be able to do that for you because my skill and my knowledge and my experience says by giving you what you want the way that you want it may not be in your best interest for the long term or the short term. So that's one of the reasons we use our standards of care as at least a starting point and a reference point to be able to provide care for you. Okay. Now let's talk about what are we going to do for you, the patient? Okay, you walked in the door and we're trying to philosophically deliver the best care. We've got what kind of medical care, and then where are you going to get it? Well, of course, there's medical care, all those things that we do on the inside. There's surgical care, all the things that we do on the outside. Well, where are you going to get it? Well, in the United States, you have the academic or university type medical centers. In some other countries, that isn't quite an easily accessible point of care. But you can also get care in the private practice world. And in reality, in both countries, or in most countries here, whether we're talking about these large populations of the US, the UK, or Australia, and then Germany, France, etc., most of it is delivered in the private practice world. Well, where do you find them? How do you know where to go? Well, Besides us as person-to-person referrals in the trans world, asking your friends, et cetera, that have been down this road, a lot of us use the internet today to find sources of care. But let me offer a little caution about this. Typically, the academic or university medical center websites are scrubbed. They have a team of lawyers and folks that look through all those things to make sure that what's put up there on the website is the real deal. Now, on the other hand, for those of us in private practice who have websites, it's unfiltered, it's unregulated, it's simply what we say. And that's where I would really offer some caution if you're trying to find sources of care for in private practice on the internet, because we all know if it's on the internet, it must be true. Not. All right. So let's talk a little bit about the who's that are providing your care. Surgeons do one thing. They change you on the outside. They simply change the way you look. They do not change the way you work. And yes, whether you're talking about gender affirming surgeries, whether you're transmasculine or transfeminine, the parts look a little different, but they're all still working. On the other hand, your primary care provider, and I'm lumping in with them the endocrinologist and all the other ologists, we fundamentally change what you are, not the way you look, but we change you from the inside out. And we really do change the way that you function and how everything on the inside works. It takes all of us working as a healthcare team to give you, the patient, the very best result and experience. Remember, you're at the center. You have hopefully your surgeon helping you. You have your primary care providers helping you. And who's that fourth rail that we have to count on? Your mental health provider. Again, that last person, that mental health provider, is absolutely critical, and we can't move forward anywhere in the healthcare spectrum without that person. Now, I'm a fairly smart person. Been doing this for a while. I've seen a thing or two, but here I am in all of my reality. And when I started on hormone therapy, what do you think I believe that I could pull off by myself? I don't need no stinking mental health provider. You know that old expression, you don't know what you don't know? Oh, folks, I learned about that one the hard way. Let me just say I was delighted that I exercised a little bit of wisdom and good judgment, and I did start my treatment with my relationship with my mental health provider. They have been indispensable for me and remain so, and I'm happy that I do have her. Okay, now, for all of the surgical types that might be listening, buckle in, because it's going to get a little turbulent here for a bit. I'm going to bash our surgical colleagues just a little bit, mostly because they deserve it. Now, surgeons are really smart people, and by golly, they are really creative and they're great using their hands. But you know what? They're just not so great looking at all the clues. They see those things that are right there in front of them. Now, Because of that, let me just suggest that starting your journey in surgical care with your surgeon is not always the optimal place to start. Have you ever been around a bunch of surgeons? They have a really hard time agreeing on anything. You got to make the clues really big for them to understand what it is that they're holding. And that's why many of us, and I've had so many patients that have gone to this surgeon or this surgeon, a group of surgeons, and they all have a different opinion, different way of how they want to approach their care. And again, I would like to suggest to you that you might want to contract things back, get somewhat of a roadmap of how you want to proceed in getting your own care. And do that with your primary care provider. And you know what? Your mental health provider has been down this road also and really does know a lot about who's out there, what's been successful, and how to go about some of these big changes. All right, let's talk about the where. Okay, where, so we talked about the University and Academic Medical Center, we talked about private practice. Let's first talk about the academic or university centers. Now, some of this is not directly applicable to the UK or some of the other countries who might be listening today, but most of the players and actors actually will be the same. And please don't tune me out as I explain some of these folks. It's generally easier to find a good academic or university medical center. They've got great reputations, they advertise and they're slick. So landing into a good one is fairly easy. It's pretty hard to get a bad one, realistically. Now, you have to understand the structure of the teaching or academic environment. You have the faculty or the attending physicians, you have fellows, residents, and students. Let's start at the bottom. The medical students, they're there for a period of weeks or a month or so, and they are fulfilling requirements. They're checking off boxes in their educational program. So they're not really fully invested, let's say, in the endocrinology section treating gender-affirming hormone therapy patients. Well, then the next step up the ladder after you graduate from medical school, you are a resident or a physician in training, getting on-the-job training, and that's it, your residency. And typically you're in that position, whether it's endocrinology or surgery, et cetera, for a period of 1 to 3 months at a time. After you graduate from your residency training, you can take some additional specialty training. Let's say those people who want to do gender-affirming surgery or be gender treating physicians, you'll do a fellowship. And that fellowship can be anywhere from 1 to 3 years. So those folks are going to be around for a while, but they're not going to be around forever. And then the big wigs, of course, are the faculty and attending physicians. Now, the faculty and the fellows really have multiple competing priorities. They're involved in research, they're involved in teaching, they're involved in administrative activities, and oh yeah, they do see patients. But there's a lot of things that they have to do and a lot of things they juggle with their time. Now, before I tell you what might be deficient with that, let me tell you what's really great about the academic and university medical center. The very best and the very brightest tend to be there. And I can tell you, it's exciting to be in an environment like that. You see people walking down the hall and that person, they have forgotten more about medical care than I'm ever going to know. And I'll tell you, it's just really the top of your day to be around people like that. Knowledge accumulates in the university system because people are coming and bringing in new information, new ideas, new activity, new research all the time. So the pool of that knowledge really grows, and it grows rapidly. And one of the quips that many of you have heard in the past, and the attribution is argued pretty stoutly, but the president of Harvard College at one of the commencement addresses made a remark that knowledge accumulates at the university. The freshmen, they bring a little in, but the seniors, they take none away. Now, the other good thing about the university is it's typically a one-stop shop. If you need a surgeon, oh yeah, we got that. You need an endocrinologist, we got one of those too. You need a gastroenterologist or whatever ologist you need, we've got that. Okay? But what are some of the drawbacks of that system? It tends not to be very intimate. You're in that exam room and you've got a medical student that comes in, they ask you a whole series of questions and they might do a perfunctory exam. And then the resident comes back and goes over all that stuff. And then the fellow comes in and then the attending comes in. And you've had a gazillion people walking in and out that door. A lot of times while you're trying to sit there in that little gown and keep yourself covered. You also know, because there's all those competing priorities of research, teaching, administration, and patient care, that it's really hard to get on the schedule to get seen. We're talking months and many months in advance to get in to see one of these specialty physicians. Plus, there is a programmed set of turnover. And generally, they're just not there very long. It's pretty unusual for a professor or attending physician at a medical center to be there for more than 10 years. So with that being said, and knowing that people are coming, and you're coming to an ologist that has a very narrow focus, the care tends to be affirmative, which means we get something done and then you go down the conveyor line somewhere else, but not here because I'm done with you. I've done my job. So here's where we really tend to fall down at these larger medical centers. We really don't have a way of providing long-term, longitudinal, preventive medical care. Now, let's leave the university and let's go over to private practice. And this will be a little bit more applicable to the UK and Australia. So where are they? If you're in the UK, oh golly, you're going to get assigned to one, if you can even get into one. But here in the United States, okay, you're going to get it by word of mouth, or you're going to check on the internet, things like that. And there are some of us, like me, we don't advertise. People can only find me. And actually, it's the majority of us that do hormone therapy. People find us by word of mouth. And we count on that. If we're doing a good job and we are advocating that people are part of this gender community, they'll spread that word. Because we're here and we're local, we tend to be closer to home. It's easy to travel to get to us. You're not traveling halfway across the country to the major medical center. And it's pretty easy to get on our schedule to come and see us. We're going to have a long-term relationship with you. We don't turn over very often. And using myself as an example, I've been here for 24 years. And God willing, I'm not going anywhere fast. The environment that you will find yourself being seen in tends to be very intimate, and that relationship is very intimate. When the nurse takes you into that exam room, There's you and me. And that's all it is. It's you and me, eyeball to eyeball. So no one else typically shares your information, shares your care during the course and content of your care. Okay, so of course, there's some drawbacks to being in a private practice. And one of those, of course, is that neon banner phenomenon. You go to the doc's office, oh my Lord, I'm a guy in a dress. Well, many of us in the beginning were uncomfortable with who we are, how we portray ourselves or display, etc. And it makes it pretty hard to sit out there in the waiting room. But think about this. I don't think I know of any medical offices that fail to have a back door. And if you're uncomfortable coming in the front door, if you're uncomfortable sitting there in the waiting room, all you have to do is ask. And we'll be happy to usher you in the back door directly into an exam room until you are comfortable in your skin coming in through the front door. And we always see that as a graduation when you're comfortable and you're happy with yourself coming in the front door. You also might think, especially if you come to my office, that gender care, well, that's only a very modest portion of the overall medical practice. Well, is that really so bad? And I would tell you, no, it really isn't, because we understand you. We are involved with you for the long term. We look at your life over a long term. And we're looking at you and we're providing care across the entire gender's transition spectrum and across the aging spectrum for you. Okay. Now, think about this for a second. You want to have a long-term relationship with some primary care provider because you say, well, we age just like everybody else. But is that really true? And I would advocate that we assume the complications of both genders. Let's take us as trans feminine individuals. Okay, we didn't have breasts to begin with. We're developing breast tissue with hormones. So now, not only did we have a very small risk before we started therapy of breast cancer, but now we're developing additional risk over what a cis male would have for breast cancer. So you need your provider to have that long-term relationship to try to manage all of the parts and pieces for who you are now and who you're going to be in the future. So again, we take a look at the whole person. We've got you right now, and you're going to be you tomorrow, so you'll be a day older. But if you add a whole bunch of tomorrows together, you're going to age. And as I've alluded to, that preventive medicine is really dismal in transgender patients. Now, let's kind of organize what we might be looking at in terms of both affirmative care and preventive care for these transgender individuals. There's the new hormone recipient. Person walks in the door and they're getting their scripts getting started. And then that person's been at it for a while and they're going to transition. Well, they go through that medical, surgical, social transition, and they come out the other side. Thank God I'm done with all those doggone doctors. I'm tired of all those tests and all that stuff. I'm going to go right off into the sunset. I've transitioned. But what are some of the pitfalls here? That new hormone recipient, there's lots of stuff to do. We're getting you started on prescriptions. We're starting to do all those blood tests and get you into the groove of being on your hormones. And then we get to the point where you're surgically and socially transitioning. The pitfalls that tend to fall on those folks, they get more medical complications. They've been on our medicines for a while. They get some of the complications of being on hormones. And we're going to talk about that next week. And these folks tend to have more mental health issues. Those mental health issues kind of got pushed to the background because they were so happy finally getting some gender affirming care. And now they've been doing it for a while. The background starts to catch up with them, or now they're getting into new social dilemmas. The friends that they thought that were going to be there to help them and support them have abandoned them, or maybe the family issues of transitioning. So again, that's where that mental health provider is just so critical. And then the person who has transitioned, here's where we start to mess up the most. Okay, so what are those things that we're messing up? And now here's the meat and potatoes of preventive care. Cervical cancer. Okay, so let's talk about our transmasculine patients. Okay, if you haven't had hysterectomy and oophorectomy, removing the ovaries, you still harbor that cervix in there. And whether you like it or not, pap smears and looking for cervical cancer really are a part of your care until that uterus goes away. And even though you've had a hysterectomy, you do have some microscopic bits of cervical tissue there, and you still do harbor some risk for cervical cancer, albeit small, but it's there. And I can tell you again from my experience, I will diagnose 1 or 2 women every year that have had hysterectomies that get into their 60s that do have cervical cancer in that little microscopic remnant after surgery. Breast cancer. 1 out of every 8 cis women in the United States, and it's, I think, 1 out of 8.3 in the UK gets breast cancer. Well, so do men. And hang on to that because I got a story about it. And of course, 1 out of every 25 men and women in the United States will get colon cancer. So you still need to have your colon surveilled, whether you're transmasculine, transfeminine. The prostate. 1 out of 8 men in the United States will get prostate cancer. So we are transfem, but you know what? We can go in there and yank out the prostate, it's still there. So you have to have somebody who will look at you to try to find that prostate cancer as you age. What are some of the other things that we miss? Well, our medications are notorious. We exacerbate high blood pressure. We're pretty much going to mess up your lipids. Many folks in combination of these medicines and some overweight can develop diabetes. If you put hypertension, hyperlipidemia, and diabetes together, what's the biggest complication? Heart disease. So somebody needs to still look at you for those things over time. You can't be the thank God I'm done, I'm out the other side, I'm transitioned, I'm leaving all you healthcare people behind. Lots of risk there. Osteoporosis, one of my favorite topics. All right. You start out as an XX female, you're transmasculine, and we take away your estrogen and we give you testosterone. You are at an increased risk for osteoporosis over time because you didn't have the estrogen. Now, you're transfeminine. We took away your testosterone and we gave you estrogen. And you know what? You are just the same. You're at increased risk for osteoporosis. Wait a minute. Estrogen and testosterone, changing it gives both of you osteoporosis? Yes. And folks, do we stumble over this one a lot? We really forget about the osteoporosis. Vaccinations. In the United States, the United States Preventive Medicine Task Force puts out our guidelines, and it's sanctioned by the CDC, who should get what immunizations. Anybody age 11 to 64 who has any kind of an immune system challenge should receive a pneumonia vaccination. There are similar guidelines in the UK. We don't do it. If you're on hormone therapy, you really need a pneumonia vaccination, and you're at higher risk for contracting things like the influenza, et cetera. So your immunizations are an important part of your care. Some of the other things that we miss, those mental health conditions that have been high in the background and they come up, substance. When people have emotional and mental challenges, substances are one of those things that they turn to and put their hands on. We also find many of our trans femme and trans masculine patients are promiscuous. They're happy. We let the bunny rabbit out of the hat, and sexually transmitted diseases happen. And we don't look into those very much with preventive medicine, but those are the things that we're supposed to. And one of the things that I've really stumbled over and have been somewhat incredulous how I could have overlooked, but intimate partner violence for our trans masculine and our trans feminine patients. Now, let's put some of these preventive things into some stories. And those stories actually are going to be about me and how I've stumbled personally in my own care and my own life over many of these very same issues. Okay, so let's tell some stories. All right, I said we started this with the standards of care by WPATH in 1979. In the old days, you had to be depressed. You had to have clinical depression to be diagnosed as dysphoric. Not anymore. But way back when I first tried to get onto hormone therapy, my treating psychiatrist was the vice president of the American Psychiatric Association, so they knew the rules like the back of their hand. Dr. Haggerty, I can't authorize you to get hormone therapy. You don't have gender dysphoria. You're not depressed. Because I wasn't. I've never been depressed. I thank God for that, but I couldn't get on hormone therapy because in the old days, when we didn't really know as much as we do now, and we didn't have the body of scientific fact and literature, there were some older rules that we had to follow. But that's why we revise our standards of care as we acquire new knowledge. And here's one of the practical things that happens in my office on a regular basis. Bubba will put their arm around my shoulder and they'll get real close and they'll whisper, "Doc, you ain't treating those kind of people, are you?" Well, here's my very self-serving motive. That's my opportunity to educate people in the community that, you know what? These are people that deserve just as much as you do. They're seeking care. They didn't choose what they are. They simply are. And yes, I'm treating those people, and I will continue to treat those people. What's that self-serving motive? When I do my social transition, I hopefully have sown the proper seeds in the community so that it'll be also easier for me as well as the other members of my community. Okay. Here's another regular one that I get. I'll go to when I very first went to my dermatologist or my plastic surgeon, but my gastroenterologist or my cardiologist, they'd see my painted toenails, my panties, my camisole, hairless body, umbilical piercing. And I would get "Oh, not you too. Really? How?" Well, again, here's our opportunity to educate the professional world too that, you know what? Yes, I am. I didn't choose to be this. I am this, and I've been like this my entire life. But let me add as a side note here, some of the very nicest compliments I've ever received have been from the nurses in those offices. Oh, I love your slip. That color looks great on you. Nurses are just wonderful and warm people, and they really understand us pretty doggone well. Now, talk about osteoporosis and screening for breast cancer. My vitamin D tanked out after I got rid of my testosterone. And I was really getting concerned about osteoporosis. So I went to another city where I tend to send a lot of my patients to get mammograms and their bone densities done at the same time. Well, I only scheduled my bone density because that was the thing I was concerned about. So I go up there and I get my bone density and I jump up off the table and I'm getting ready to head towards the door. And Tim, who is the technician, Tim is family. And he saw into me pretty easily. And as I sort of head towards the lobby, Tim grabbed my shirt sleeve and said, "Doc, don't you need your mammogram also?" Now, freeze time. I'm standing there like the deer in the headlights, like, oh my God, I've been outed. Now, unfreeze time. What do you think was the first thing that came out of my ever so educated mouth? Me? No, I don't need a mammogram. Thankfully, Tim was very understanding, put his arm around my shoulder, said, "Yeah, Doc, you really do need a mammogram." So off I went, I got my mammogram. And let me say this, have any of you had a mammogram? Oh my God, that is the most infernal device. I'd rather have 10 colonoscopies before having another mammogram. But as much as I carry on about that, it's important for all of us. And here's one of my very favorite stories. My wife and I were out at dinner in another city at Applebee's. We had just finished, and the waitress brought our check, and I was getting ready to pull my credit card out of my purse, and someone touched my arm, and I looked, and it was Tom. Tom is a rather outspoken, very important member of our LGBTQ community, and recognized me and leaned into my ear and said, "Doc, I didn't know that you were family." And again, my ever so educated brain just plopped out with, "Well, no, Tom, I'm not family." Not to be deterred, Tom leaned in between me and my wife and said, "Doc, don't look now, but you're a lesbian." It took about 5 microseconds for all three of us to realize the humor in that situation. And we erupted in laughter in the middle of Applebee's. Well, actually, the people in the booths around us had overheard that situation, and they started laughing too. It was a hilarious situation. It underscores that we so often overlook the obvious. We change, we're challenged, we need to think of ourselves in different ways. Now, if you look at those stories that I told, many of us will find ourselves somewhere in one or more, or even all of those stories. Because these are things that make up our lives. And even me, I think I'm a professional. I've stumbled over several items, but that's why you need to be an advocate for yourself. You need to know a little bit about what you should expect in terms of your care. Now, we talked about the sites of care. We've talked about content of care, mostly in terms of preventive and mental health. Next time, we're going to talk about a real deep dive into hormone care. But you need to be the person that runs the show. Now, I'm going to show you our cartoon. And this cartoon, a little saucy, but I promise it's not censored. My daddy gave me this cartoon. I carry it with me always. It took me several decades to figure out what this really meant. And here's how I'm going to tell you it's applicable to me and to you and your life. You are a musician and you're joining other creative musicians and you're going to play from a sheet of music. All of you are talented. All of you are necessary in terms of the success of bringing that music to life and making it beautiful. We're all necessary in that healthcare team. Now, if you work with your other musicians, the music will be beautiful. But if you decide to go it alone, or you try to shortcut it, or try to be a star without support, it just won't turn out so well. All right. Now, Liz, come on back. Let's try to answer some questions from our viewers. And also, let's have our moderators come help us.
All right. Thanks so much, Dee. Very informative. And let's see, I think we need to, we don't need the presentation. There we go. Okay, so presentation is gone. So, yeah, we have quite a few questions here that people have put up. And Cynthia Dubois, pardon me. Sorry, Cynthia, has quite a few questions here that I think we just want to start off with this one. Jazz and Kimmy, feel free to just pop these up here, but I'll start off with this one.
Okay.
So Cynthia, Cynthia wants to know how we can handle unsympathetic and uncaring doctors, especially when they claim that they're transgender friendly. It's a good question.
Well, I'll answer part of that. Remember, what we portend ourselves to be is not always what you're going to get. Transgender friendly doesn't necessarily mean that they are really advocates and intertwined with the provision of gender care, and maybe they're just doing it begrudgingly. I think that your mental health provider certainly can offer some additional information in terms of how are you going to approach that doctor. Now, I tend to be a little direct with my care, and I tend to be a real advocate of reaching out and grabbing the doctor by the shirt collar, getting nose to nose with them, and telling them how I think and how I feel. But basically, if you don't feel like you're getting what you need from that physician, there are other folks to see and there are other places to go. If you're having difficulty finding somebody that is both compassionate, caring, but also skilled at providing care and listening to you as the patient. If you're having difficulty, if your mental health provider can't point you in the right direction, you can reach me through the site, and I can help you identify some folks that I know that may do a better job for you. And certainly I can't endorse any of those here on our broadcast. Okay,
So,
got it. Another part of this, what resources are there to find those really transgender friendly doctors? So much of this is word of mouth. That's really, fortunately or unfortunately, that is really the biggest thing. Talk to your brothers and your sisters that have walked this path. Who's helped you? If it's not somebody close to you locally, you may have to travel a little bit, but that word of mouth is important. Again, your gender healthcare provider who's got experience might know some folks. They tend to be a little hesitant about recommending, but again, if you're stuck, please send me a note on the site and I'll be happy to help you.
All right. So Bree'd like to know if you've been open about your status with your patients.
The short answer is no, I'm not socially transitioned yet. All my healthcare team knows, family, my office staff, we're moving towards that day for which I'll be socially transitioned. I think those things are pretty obvious, and most of us are pretty intuitive. And yes, some people just flat out ask. I try to be very clear when people do. I also have to be a little politically savvy in that I both want to control my timeline and my narrative. Of course, my narrative is clear. I may not be able to completely control my timeline, but sometimes you can't share everything you know and everything that's there.
Okay, Dee, from a couple of our comments that we had, there are a couple of questions that we can ask through our comments, like from Renee. What is the risk of kidney disease with spironolactone?
We will definitely talk about that in depth next week. But generally, a lot of it depends on what are some of the other background issues that you have. Hypertension, diabetes, hypercholesterol, those do put you at some additional risk. But on the whole, spironolactone is effective and safe. Here in the United States, we use it all the time. And maybe not quite so much in the UK, kind of somewhere between UK usage and US usage down in Australia, but generally safe and effective. But that's why we keep you on such a short leash in your gender care. You're coming back. We put our hands on you. We listen to you with the stethoscope. We do your laboratory tests to make sure that horse is not leaving the farm.
Okay, and then another one that we got was from Monique. She was wondering, when they're being treated at the VA, Veterans Affairs, are they in direct violation of their Directive 1341-4?
I'm going to have to plead a little ignorance about what that particularly is.
I wish I knew. I'm just going by what I was. Okay, to put it a different way, are they possibly violating their own directives set by the government?
Some of this answer is, of course, political, and I will elect to sidestep the political part. Everything in healthcare in the United States comes down to dollars and cents. Who's paying? With veterans, the government is, DOD is the source of that payment mechanism, and they have their rules, et cetera, about how they're going to treat people, what kinds of things that they will treat them with and for, and surgery, et cetera. I do run into limitations essentially with every insurance company here in the United States. It's also a mixed bag in other countries, at least in terms of waiting time to get into care. But veteran care is really a very special item. And it has been, I'll say, something that I've had to deal with quite a bit here. In South Alabama, we have a lot of veterans. But yeah, they're kind of in a tough spot right now.
Okay, when it comes to breast augmentation, we did get a couple of comments about the different types, textured, smooth. Also, would it be, what is the difference with the textured, smooth, and does it go and does it affect the different types, either saline or silicone?
Yeah. There's arguments pro and con for all of them. And some of those do have more issues than others. The breast surgeons really know that a whole lot better than I do. I'm not going to plead ignorance, but they just know a whole lot more than I do. Plus, I'm going to have to go down that road too. So I will certainly be more knowledgeable when I need to. But that's as much insight as I can offer. You really need your specialist to help you. And they really need to be able to articulate for you what the risks are and what the benefits are. If they cannot articulate those answers to your satisfaction, you need someone else. You need a different surgeon.
Okay, another good question. I don't believe it was asked, but we're going to ask it here. When someone is considering going on HRT, is it recommended that they talk to a therapist first to make sure that they are going down the right path?
Now, at the beginning of this episode, I made it pretty clear that I absolutely will not see patients that do not have an active relationship with their mental health provider. And most of us simply won't. You need to know before you go. There's a little spin on that particular question. I'll get a therapist will call and say, I just met with them. They are in crisis. They're transgender. There's no question in anybody's mind that they're transgender. They really need to be on hormone therapy. Can I send them over there and can you get them started on hormones? And my answer is a very steadfast no, not just yet.
Yeah, go ahead.
They need to have relationship with you, and they need to really see what are some of those other things in the milieu and the scene of your life that also need attention. Hormones may not fix everything from the beginning, but yes, you really need to start with the mental health provider before you go to a medical provider for that hormone therapy.
Okay, like I said, these are all great questions that we had from our audience, and of course, some that I have come up and that Liz has come up with. It's a lot. There was a lot of information that was given today. I'm sure a lot of people have more questions than even we can even think of, and they can think of at the time.
Well, and one of the things I saw flash across the screen, and thank you, Dana, you're correct. The WPATH does have a list of some physicians, and you can find some things on their website. Thank you for that.
I don't think this question has come up yet, Dee, but it's something that I wanted to ask. And it concerns people that maybe can't afford care. They don't have insurance. They're trans. They may be going through Planned Parenthood, but they want something that's better than that. What options do they have out there? And then I understand this is going to be, to some extent, will be based on where they're located. But I mean, what options are there for people that don't have a lot of money?
The good news is there usually, for the medical care, is not a lot of money involved here. And again, one of the things we're going to talk about next week, and I'm going to lay out chart and cost. These medicines really are not very expensive. And we can, I'll say my experience is at least 1/5 of all the people that I see have no insurance benefit for their medical care as transgender patients. I don't have a problem seeing them because we can get their medications at a very affordable cost. Most of us physicians have agreements with our laboratory companies that they make a gazillion dollars on insured patients for every CBC and metabolic profile that they do the blood test for cost. Every quarter, when I do regular blood tests on my new hormone recipients, the blood test, blood count, metabolic profile, testosterone level, estradiol level, parathyroid hormone, $32. So, yeah, this is just not astronomically expensive for your medical care. And for many of the patients, it's the same kind of co-pays or deductibles and things that they would have if they had insurance. Now, I'm a medical doctor. Surgery is a whole different issue. Okay, and that's really where the big expense comes.
Mm-hmm. It is. Just kind of expanding on the people that don't have a lot of money. I know that DIY, do it yourself, is not really a recommended course, but I think maybe that's something that's worth talking a little bit about, because there are people out there that feel that they do need to go the DIY route for whatever reason.
Well, first of all, I've hammered about your mental health provider. Kids don't leave home without it. It's just that important. I get plenty of folks that come to me as new patients that have started down the DIY and found that was really unfruitful and that they weren't getting the kind of benefit results that they wanted, or they had side effects. Knowing how to look at you as a transgendered patient and how to monitor you step along the way really is important. And that's not something that is very easy. I say you just can't do it as an individual and be successful over the long term. And again, next week, we're going to be doing a deep dive into what are the good, the bad, and some of the ugly that happens with our hormonal therapy.
I just wanted to put a comment up here from Ellie, who's located in the UK, and anyone that's even remotely aware of the NHS situation over there. Yes, the wait times are absolutely ridiculous.
Yes.
Over there. So, I mean, I know we're all based in the US, but do you have any knowledge of what the options are over in the UK?
Yes, I've dealt with several of the folks from UK through our websites. If you're going to go through NHS, National Health Service, those wait times are just horrible. But it doesn't make any difference whether you're talking about transgender care or if you need a hip replacement. By golly, everything's just going to involve a long wait. Well, you can short circuit that, and you definitely have those options, even in UK, Australia, etc., for getting your care outside of NHS. And the medications, again, are just not that expensive. You may have to pay a little bit more for your medical monitoring, but they're just, for most folks, are not going to bankrupt them. I'm not trying to minimize the impact, but you do have options outside of the NHS.
I just heard somebody typing something. Do we have any more questions?
I apologize. That was my fault. Questions? We can go through a whole bunch of more questions. It is, how do we go by? Like, we're getting a lot that'll say, like in the New Zealand area, there's very few private medical insurance companies, and it's basically paid by the government down there. And basically, how does it affect each individual country? Are they still under the standard WPATH guidelines?
Yes. Now, I let off. It doesn't really make any difference what continent you're on, what ocean is between you and me, what your payment or healthcare system is. The standards of care are best medical practices. Now, and that is laid out in a very easy format. And I would recommend, and I'm sorry I didn't say it, every one of us, even if you're not a physician, read the standards of care, because the roadmap is very clear. And that provides us, as the recipients of care, the roadmap. But it also provides that same roadmap to every physician treating patients. I will also say, and repeat myself, there's more than one way to do this, more than one right way. The standards of care from WPATH are not the only way, but it gives us common ground based on the best clinical information that we have, and our information is incomplete, but at least it lets us all start somewhere in terms of providing care.
Okay, and on the subject of the WPATH, have they recently updated, or are they about to update it? And how long has it been since they updated it?
Okay, September the 15th of 2022 was the publication date for version 8. And oh yes, they're pounding it out, and they're coming forward with another one pretty soon.
That's good to know. And we had a comment from Bree. Thank you, Dr. D.
Hey, thanks, Bree.
And we know it was a very, very good presentation. I mean, I'm sure our listeners learned a lot. Heck, even we learned a lot by just watching it. Even though we've been going over it with you, we still learned a lot more now than we did when we were getting ready for this. I'm sure Liz can agree with me.
I do. Yeah, we're getting close to the end of our time here, but do we have any more questions from anyone that's out there watching? If you have any questions, please post them in the comment window right now.
And by the way, for those comments that are scrolling up and down, we're going to go through those, and we're going to collate those, and we're going to bring those forward. We're going to have an episode strictly to focus on answering those questions for you and answering those concerns.
Well, this isn't really a, let's see, is this a question? I'm going to put this one up here anyhow. It looks like somebody's happy.
Oh, I was going to do the same thing. Trust me, you beat me to it.
Yeah. Yes. Yeah, that is, unfortunately, that's the reality. I think we're, depending on where you live, it may have to be private pay. Okay, let me hide this. Well, a little bit of housekeeping while I'm thinking about it. This session has been recorded and it will be available for on-demand watching at a later time. It should be up on CDH and TGH later today, this afternoon. If you're based in North America, that is. And our next session, we should have an announcement for the date on that coming very shortly. So Dr. D's deep dive into HRT. We should be making an announcement on that soon. I'm expecting it will be this month in February that we'll be doing that. And then we'll be doing a strictly Q&A session at some point after that, I believe. I'm not sure what the timing is going to be on that. And then just bigger picture, this isn't just going to be webinars about transition. We're looking at a whole bunch of different subjects that people have got interest in, fashion and makeup and voice therapy. And there's a pretty long list of things that we want to look at. So we're looking at doing this on a very regular basis going forward. So perhaps even once a week. So.
And yes, and thank you, Dr. D. It was a pleasure having you with us today. We and especially for the inaugural webinar for our new streaming service. I believe that it went very well. I'm seeing a lot of comments where they're thanking you. They're saying thank you, Dr. D. It really hit home to what a lot of our members actually are looking for the answers for.
Oh.
We get these questions all the time.
Oh, one just popped up. I'm gonna put up here. How do you go through? I'm not sure exactly what the question is that's being asked here, but
for a lot of people, we're just overwhelmed, especially in this transgender world of ours. It's pretty easy when your provider says, you need a colonoscopy, or you should do this or that. Those things kind of roll on. For us, though, in the transgender world, we generally have to drive the show. And that's why I want to try to equip and arm all of us listening how we're going to be our own best advocates. What is it that you should expect? So you go into the insurance company and say, hey, look, the WPATH standards of care are saying this, this, and this, and this. I need this done. Asking is not the way to go. I'm a real believer in, if the train's coming down the track and it's in your way, kick it the hell out of the way.
Okay. Liz, you have anything else?
Nope. We are just about out of time. So any remaining questions, we will get to those at a future date. So just check the website, CDH and TGH, later on today if you want to re-watch the program, or I guess anyone that's out there that couldn't watch it, just let your friends know that it will be available to watch later on today. And that's it.
And thank all three of you. You guys have been great. Thank you so much for all the work that you've done.
We did it for you. We did it for you more than we did it for ourselves.
Thank you.
We did it for a while too.
Thank you, folks.
All right. Bye, everybody.
Have a good one. Thanks for watching.
Yep.